acid process, it travels down a concentration gradient, right? So our fresh oxygenated blood comes in with nutrients and oxygen, it gets into the capillary bed, and it delivers them, and then it picks up carbon dioxide and waste and moves it out, right? Simple diffusion. Then the other one were transcytosis, two different types of transcytosis. What were they? Endo and exo, right? Endocytosis, something attaches to a receptor, most easily to understand, attaches to a receptor. Cell wall swallows it, or cell membrane swallows it, brings it into a vesicle. Exocytosis, opposite. Whatever this cell has created or needs to get rid of, either way, it's in a vesicle, pushes it out, opens into the cell membrane and out into wherever it needs to go to circulation or what have you, right? So simple, all right? Now we're going to talk about bulk flow, which is the more, it sounds the bulky, it's the majority of the way filtration and reabsorption occurs. It's a pressure-driven process, all right? So it's a difference between the pressure within the vessel and on the outside of the vessel and the interstitium. Remember now we're talking about the interstitial fluid that surrounds that vessel, right? Okay, so we are bringing the blood in with the stuff in it, and we're delivering it out into the interstitial fluid, into the cells, so on and so forth, okay? So we're going to think two main mechanisms are filtration and reabsorption, all right? And filtration is going to be flow out of the vessel, okay? Reabsorption is going to be flow back into the vessel. All right? Start from there. Exactly what I just said, but I want you to also, on this part right here where it says filtration is into the interstitial fluid, after into the interstitial fluid, I want you to write out of the blood. All right? Because sometimes it's easier for you to have a point of view from one space rather than multiple different places. So if we're thinking from within the capillary, filtration is pushing stuff out of the blood. All right? Reabsorption is then grabbing stuff and bringing it back into the blood for return to circulation. Okay? Does that make sense? All right. Now, what is on here is absolutely true. It is. Filtration is movement into the interstitial fluid, but again, like I said, if you conceptualize just what's going on in the vessel itself, sometimes it's easier to think about it that way. Okay? Pressures that promote filtration. So again, these are pressures, and we're going to go over each one, that promote movement out. Blood hydrostatic pressures. Everybody understand the word hydrostatic? Fluid pressure, right? So this is stuff that's forcing a pressure exerting against the capillary wall out. All right? Interstitial fluid osmotic pressure is an osmotic pressure from protein molecules or whatever have you that surrounds the interstitial fluid, that are in the interstitial fluid that surround the capillary, pulling fluid out. Okay? We're going to go over these individually. I'm just giving you guys a prelude here. Reabsorption, blood colloid osmotic pressure. So we talked about what colloid protein, or what colloid pressure is, what a colloid is, like albumin, right? Large protein molecules in the blood that exert a pressure to pull water, okay? Pull water into the vasculature. And then interstitial hydrostatic fluid pressure is the push force pushing stuff in the vesicle. All right? So here is the explanation further. Hydrostatic pressure. These are promotion of filtration. See the top? So this is pushing or pulling stuff out. Movement out of the blood. Okay? Movement out of the blood. Hydrostatic pressure. You know what you can think about that is? Blood pressure. Is it just blood pressure? No, but it's an easy way to think about it. It's blood pressure. It's the force inside the vessel that is pushing stuff out. Okay? Also, don't need to know these numbers, precise numbers at the bottom. What you need to understand is that on the arterial side of the capillary, it's higher pressure. And at the venous side, the venual side, it's a lower pressure. And the net difference is the filtration that's occurring. So the stuff that's leaving the blood, okay? Is it important that you know 35/16? No, it isn't. You just understand that the pressure changes and goes down. But even that conceptually doesn't make sense to you. The heart pumps, blood flows. As it starts to make its way farther and farther away, the pressure does decrease. By the time we get back all the way into the superior vena cava, the right atrium, there's very little of any pressure left moving that blood versus the other side. All right? So just understand that. Now, interstitial fluid osmotic pressure. Pulls fluid out. All right? Usually it's a very, very low, if anything at all, contributing to it. And why? Basically, on a basic level, where are your plasma proteins, so named, supposed to be? In the plasma, right? In the serum, in your blood vessels, in the capillaries. So there's not supposed to be, there shouldn't be a large amount of oncotic molecules in the interstitial fluid. All right, it's not a very protein-rich fluid, which means there's not a lot of things out there that exert that oncotic pressure to pull stuff out. Does that make sense? Right? Most of the proteins and the things that exert that osmotic pressure should be inside the vessel, because where do we need fluid? Inside the vessel. We don't need it in the interstitial. Has anybody ever heard of third space before? Third spacing of fluids. Anybody ever heard of edema before? Right, so edema is what you call a third space. So remember we talked about fluid compartments, intracellular and then extracellular. But extracellular is broken down into intravascular and interstitial. That interstitial is the third space. It's fluid really where it doesn't belong, right? Think about somebody who's got big swollen edema, they have maybe heart failure or something like that. Their fluid isn't in the usable space. So that is a long explanation for interstitial fluid osmotic pressure. Should usually be very non-contributory because, again, we don't need or want the proteins there, and we don't really need or want fluid to remain there very long. Okay? Does that make sense? You got it? Yeah? Okay. All right, now we're switching now to movement back into the vessel. Okay? So filtration was movement out of the vessel. Now we're talking about forces that can put stuff into the vessel. Okay? Okay? Reabsorption back into blood flow. So, if you want to think about it this way, the opposite of the force that we just talked about, the interstitial fluid osmotic pressure, the blood colloid osmotic pressure is sort of the opposite of that. It's pulling our fluid in. Albumin, large plasma proteins, molecules that exert an oncotic force, meaning they can pull water towards them, are in the vasculature, and that is promoting reabsorption of stuff back into the vessel. Okay? Does that make sense to y'all? Has anybody ever heard, anybody watched an old war movie where they gave somebody albumin? You give somebody albumin so you can have, so it will increase the albumin in the vascular space and pull water towards it to increase vasculature, increase the intravascular volume. Now you still give albumin these days, but I was saying most of the time you're watching Saving Private Ryan and they give albumin. And maybe you guys are familiar with a product called hetastarch that we used to use, right? Again, just a large starch molecule that pulls fluid towards it to try to expand the intravascular volume. All right? And then interstitial fluid hydrostatic pressure. This is like a push pressure from the interstitial fluid. Usually, again, not contributory at all. Zero, you see? Because there should not be a sufficient pressure in the interstitial space, in the fluid surrounding the cells, in the fluid surrounding the capillaries, that would be able to push anything into the vasculature. Does that make sense? Because why? The fluid shouldn't be there at any great amount, right? There is if it becomes pathologic and you have now edema, swelling, third spacing, then it starts to alter these numbers. But in general, hydrostatic pressure in the interstitial fluid should be zero, okay? Are we still together? Everybody? Okay. I just want to make sure. So, when you put all those forces together, you add the filtration forces, you add the reabsorption forces, you get the difference, that's net filtration pressure. All right? And net filtration pressure is going to determine which force wins, essentially, right? And generally it's not going to be a net zero because we need filtration and reabsorption to be happening, delivery of solutes, electrolytes, so on and so forth, right? So we're going to show you how to do the equation here in just a second. But remember Starling's forces in the heart? To a degree, the greater the stretch, the greater the contraction. Starling also has forces here in the capillaries and hemodynamic flow, is that in general, volumes are going to balance out, okay? So what we deliver is about the same as what we pick up, okay? Not exactly, but about, okay? All of the Starling forces have the caveat of within limits, or to a certain extent, or something like that, okay? There is no perfect system, especially in human physiology. So, this is how you calculate bulk flow, okay? Net filtration pressure. This one you will have to remember, you guys, okay? You'll be given the numbers, and you just have to calculate it and tell me, is this a filtration pressure or a reabsorption pressure, all right? Meaning, if it's a positive number, what's going to be happening?
Filtration.
Stuff is being pushed out of the blood, right? If it's a negative number, what's happening? Stuff is being pulled in. And so, now, having said that, this should make sense. On the arterial end, what do we do? This is the delivery side, right? The arterial end of the capillary bed is the delivery side, right, you guys? It's the one, it has all the oxygen, it has all the nutrients. That's the delivery side. So that is, on that side, we're pushing stuff out. We're delivering the cargo, okay? On the other end, the venule end, if you would say the venous end of the capillary, so the post-capillary venule, right? Remember that from yesterday? We have a negative pressure, so what does that mean? That's the receiving side. We're picking up waste and carbon dioxide and we're taking it out of there. Does that make sense? Why that would be, on average, why those would be the numbers? Does it matter if those are the exact numbers? No. But does it matter that we're delivering and filtering on the arterial side and we're picking up and removing on the venous side? Does that at least make sense? Yeah? Okay, good. And as you can see, it's a pretty simple math problem, right? Especially if you give the numbers. Oh my God. Splash coffee on my face. Did nobody say that? You should all be laughing at me right now. All right, so if we look here and say, remember everything is about, right? Nothing is absolute. Can't be, or it's be too easy. We have this little guy right here we haven't talked about yet. Anybody familiar with the lymph system at all? Heard of a lymph node, swollen node before? This is what we're talking about. What the lymph node system, or the lymphatic system is sort of an adjunct to our circulatory system. So it picks up overflow, if you want to think about it that way. Especially of the waste products, because it is moving back like the venous system, back towards the central, back towards the heart. Okay, eventually this stuff does dump into the large thoracic ducts and then into subclavian veins. We'll get there in a minute. But what I was saying here, people are going to notice filtration, average 20 liters. This side says 17. Well, we just said, Frank Starling says, what's absorbed is about what's filtered, or vice versa. The excess of that, the difference in those 3 liters makes its way generally into the lymphatic system as sort of an overflow. All right? And that is not pathologic, that is normal lymph flow. Okay? A lot of what lymph picks up is larger proteins, larger molecules, and then some senescent cells that have to go and be processed as waste, essentially. Okay? So lymph fluid is a lot thicker milkier, which is a gross term, but if you want to think about it that way, than blood. Okay? And we're not going to talk about the hydrodynamics of lymph fluid because nobody cares. All right? But all of this picture is just everything we just talked about as a diagram. Okay? Because I know that some people it does help to just, instead of seeing it on 8 different slides with words, sometimes it just helps to look at this and say, okay, I understand. Big takeaway again, arterial end, net filtration, venous end, net reabsorption. As the largest takeaway of everything we've talked about so far, that makes sense, I hope, to everybody? Right? The delivery and the pickup side. All right? Am I going too fast for this morning? Is everybody okay? Just want to make sure. All right, so blood flow again, the remainder into the lymphatic capillaries, okay? And we're going to do a brief discussion on lymph right now. But ultimately what you need to know is in a non-pathologic process, so this patient doesn't have any kind of infection, any kind of edematous process, or any kind of altered lymphatic flow, it is normal for the lymph system to pick up about that much material and then ultimately return it back to venous circulation via the subclavian arteries, or veins, excuse me. So, proteins, right, particulate matter, stuff that really doesn't belong in blood and so on and so forth. I told you some products of infection, right? So, it's just kind of a alternate waste removal system, if you want to think about it that way, all right? Let's take a look at it. So, these are the lymphatic ducts, and I want to draw your attention to the way that it flows. So, everything, if you're looking, what is the direction of flow here? Everything is flowing centrally back up to this area up here where the large veins are. Okay, so everything's flowing back centrally. So it's like the venous system in that it's returning stuff. It's not delivering anything. Okay? So, if you look here, the left side, right, because we're looking at anatomical position. So this is the left side, right? So everything on that side drains here into this large thoracic duct right there. So most of the lower body, the intestines, the stomach, right? The left arm all drains right into here. The right side, conversely, drains into this smaller right lymphatic duct. And why is it, who cares? Well, if you and everything's flowing centrally back towards there. So if you have swollen nodes on the left side, depending on where they are, they may be evidence of an infection or cancer or something else in the lower extremity. So knowing what drains to where helps you understand where the infection, where the neoplasm might actually be in the body. All right, and we'll get into a good clinical correlation here about that in just a second. But this just says that. The reason I changed this, I think I had this in bold on yours. It's not called the large thoracic duct. It's called the thoracic duct. It just is large. So I didn't want anybody to get confused on nomenclature, okay? Clear enough? See what I'm saying? Okay. And if you want to blow up, again, like I said, both subclavians pick these up. You have the thoracic duct draining into the subclavian vein on the left side, and the right lymphatic duct draining back in. So that's where it all ultimately returns into venous circulation. Okay? And that, the body image there, conceptually was what I was drawing on the other one. Everything in purple is drained on the right side, but everything else is drained on the left side. Okay? And here's a good clinical correlation. We'll talk about it again in GI. I don't know how well you can make it out, but let me draw your attention to it. This little chestnut here doesn't belong there. So, it's on the left side of his body, right? So what that is called The node is called Birchall's node, all right? The sign is called Troussier's sign, you see at the bottom there? So it's two different things. The node is called Birchall's node, but the palpable, if the node is visible and palpable, then it's called Troussier's sign. Why does it have to be two different things? I don't know, all right? But what that is a sign of is gastrointestinal cancer, and most commonly, most pathogenomically, that is for stomach cancer. So Birchall's node or Troussier's sign is usually associated one-to-one with stomach cancer, and why? Because that's what drains on that side, right? Even though the stomach's way down here, supraclavicular node, you wouldn't normally think. You might think supraclavicular node, maybe it's Hodgkin's lymphoma, maybe it's another kind of lymphoma, maybe it's some kind of more upper extremity or upper thoracic neoplasm. It's actually from the stomach. So again, knowing why that would occur, knowing how the lymphatic drainage occurs, helps you understand and associate that clinically. Okay? Does that make sense? And edema, so back to clinical correlation stuff. So those pressures, if they're altered for some pathologic process, then you're going to, or you can, run into a situation where your patient has an excess of filtration and a lack of reabsorption. And what does that mean? That means a whole lot of stuff is being pushed out and not enough stuff is being picked back up. If you want to think about that stuff as water, okay, just conceptually, then what's going to happen is eventually the areas where this stuff is being delivered, the water is being delivered, is going to start to swell. And that's edema. Okay? So if you have excess filtration, this can be for a couple of reasons. One of the main ones, I know there's a lot here, thermal injury, so burns will definitely do it, but infection or inflammation can alter capillary permeability significantly and thereby allow these proteins to leach or escape into the hydrostatic, into the interstitial fluid, and that would alter those mechanisms, right? So if we're leaching a lot of these plasma proteins that are supposed to be in the blood into the space around the capillaries, then what can happen? They can start to exert that hydrostatic pressure and continue to pull stuff out of the vasculature, right? And edema is swelling. So water is flowing in the opposite direction as it should. Does that make sense? Right? So we have plasma proteins in a space where they don't belong because the capillary walls have been altered by infection, inflammation, or other. And now we have a force pulling fluid out of the blood. Does that make sense? Okay. And then, if we have inadequate reabsorption, which is another reason, and I'll give you a couple of examples here, and that has to do with albumin again. So, let's say in a person who has a kidney disorder, right? We'll just leave it at kidney disorder. Sometimes what can happen with those kidney disorders is that a lot of the capillary permeability in the glomerulus, which is the capillary ball in the kidneys themselves, leaches out plasma protein, so albumin can escape, and it just comes out in the urine. So they're losing that oncotic pressure in the vasculature, so they don't have enough plasma proteins. So that then lowers blood colloid oncotic pressure, right? If you don't have enough protein in the blood, you don't have enough force pulling and helping to keep fluid in the blood, and so what happens? It leaches out. Okay? So it's a very similar mechanism to the other side, but this one, there's just not enough protein in the blood. Not because we're losing it to the interstitial space, but because we're losing it to urine, or lack of production, or what have you. You guys with me? Yes, sir.
So would this be like ascites?
Yes, exactly. That is a form of severe edema in the abdomen. Ascites is what he said. So if you've ever seen somebody that has sort of, it's like typically it's a hepatic disorder, right? That produces ascites. So you have like a person that's got like a skinny fat thing and they just very rotund abdomen. That's pathologic ascites because this mechanism, they're not producing enough albumin and they're losing albumin and their capillary permeability is altered so that fluid is just leaching out into the interstitium and it ends up in the peritoneum, which is the abdominal cavity. Yeah. Also, just even more simply than that, swollen legs, somebody who has a reduced amount of circulation. So any pathologic edema is one or both of these processes happening, okay? So that's what we call pitting edema. We can actually push in and the fingerprint stays, okay? A lot of times, pitting edema means that we have an altered capillary permeability. We have a lot of protein in the interstitial space because it's like gel. It's like one of those, those fidget toys, the gel cubes. Really is kind of like that. So it feels mushier versus non-pitting edema where they still have edema, but this is a lot more tense, like a lot more tight, if you will. So most of the time this is more just fluid rather than, it's fluid loss. So this is more like somebody who would have that protein loss through nephrotic syndrome, like the kidney disease. Right? Does it matter? It does. Right now, just want to make sure that everybody sort of understand how edema comes about. Yes? Is this a lot for 8 o'clock in the morning? You guys all right? Okay.
Question. The interstitial hydrostatic pressure.
Yeah.
Obviously, if it's moving out of the bloodstream, it's increasing because you're pushing it all into the interstitial space. But it's not large enough to then push it just right back on the other side.
No. So interstitial fluid hydrostatic pressure, there shouldn't be tense enough. If it is altered, it's probably because of that second picture. Somebody who's got severe edema that has enough pressure pushing against the space to create some amount of force to push back into the bloodstream. But even then, it's not a significant 20, 30 millimeters of mercury. It's still maybe single digits. So it's not a significant contributor to filtration or reabsorption, excuse me. Does that make sense?
Yeah.
Yeah. Okay, any other questions? Okay. So, now we'll talk about a little hemodynamics, a little fluid dynamics, a little physics. Very little. So, series versus parallel flow. Where have we already seen this? Where? The capillary bed, right? And the capillary bed. Okay? So, what would this represent? Assuming all precapillary sphincters are closed, what does this guy represent? Thoroughfare channel. That's right. Okay? One way to go. From the arterial to the capillary directly into the postcapillary venule. Now, the other side, what does that represent? That represents the precapillary sphincters being open. So blood can flow into multiple different avenues, and multiple different capillaries, all right? Now, which of these two do you think is going to be a slower net velocity? Huh? B. All right? Because of the radius of the tubes that it's going through, right? And that's an important point. That's what we're going to get to. That is the overarching theme here, is the radius of the diameter of the tube has the greatest effect on the actual velocity of flow, all right? And why, if you want, now think about this, why would we want slower flow through the capillary beds? Exactly. So that we have time to drop stuff off and pick stuff up, so we're not just flying through there. So we have an efficient system, right? Good, now we go. We talked about compliance before in terms of ventricular wall. What did I say compliance was? Stretchiness. That's right, stretchiness. And that is essentially what you can think about it, all right? In which the compliance here in the arteries, what contributes to their ability to withstand higher pressure changes? The elastic fibers, the elasticity. In the veins, their compliance, their distensibility because of their collagen and this overall size of the lumen have a higher, technically a higher compliance because they allow for more volume changes, right? So pressure changes versus volume changes. Remember what we talked about? Where is most of the blood at any given time in your body? In the vein, on the venous side, right? Yeah. Capacitance vessels. Remember? All right. And then elasticity, again, that, just think about that with the arterial side, right? What do we need that for? Picks up that potential energy, squeezes it, blood moves forward. Talk about pressures, all right? Axial, longitudinal, okay? Going in the direction of blood flow. Circumferential, pressure around the vessel on the outside, and radial is pressure against the wall. Radial is like intravascular pressure. Or excuse me, take that back. Radial is not intravascular. It's a pressure against the wall on both sides. So we'll talk about what intravascular pressure is in just 1 second. But you see where it says gravity can play a small role in axial pressure? Just take that pipe and tilt it vertically. Think about your descending aorta, right? Think about your vena cava, right? Pressure is affected by gravity somewhat, right? Remember, we referenced the muscle pump for the venous side to help get that back up against gravity. All right, hydrostatic pressure. That's the intravascular pressure, I'm sorry that I misspoke. Alright. Pressure that is exerted by the fluid against the walls of the vessel. And the radial pressure is actually the difference of the intra and extravascular pressure. So the pressure exerted outward by the blood and inward by the interstitium or whatever. Okay? Alright,
Which pressure?
which pressure?
You said that's outwards, inwards, which one was that?
Radial pressure. Radial pressure is the outward pressure versus balance with the inward pressure. So the pressure trying to keep the tube open and the pressure trying to collapse the tube, if you want to think about it that way. What's more important? Hydrostatic pressure. Okay. Some basics. And honestly, you guys, let me add this. The honest, easiest takeaway is that blood flows slower through smaller tubes, right? That's smack you in the face obvious, I'd imagine, right? But where the difficulty comes in is understanding surface area, where most blood is and why and how it's flowing through there. So that's what we're going to get to. So the takeaway is that smaller blood vessels, blood flows slower just because. But we're going to put a little bit more nuance on that. So just stick with me on there. Velocity and flow, okay? Volume, amount of blood, and speed of blood essentially is volume and flow, okay? Flow is the amount of blood and velocity is the speed at which it moves. And total surface area of vessels, right? So which vessels do you think have the most total surface area? Capillary. We have an aorta. We have millions, hundreds of millions of capillaries. So if you flay open all of the capillaries, the area of all of those capillaries is significantly, exponentially larger than the area of our single aorta. All right, that's what kind of is the nuance that doesn't make sense to students, right? Total surface area, okay? Total surface area. That's where we're gonna get, okay? So, cross-sectional area inversely proportional to velocity of flow. What does that mean? Somebody tell me. Seriously, I have no idea what that means. Somebody, what does it mean?
One goes up, the other goes down.
Huh?
One goes up, the other goes down.
That's correct. So as the area goes up, what's happening to velocity? It's going down, right?
Thank you.
And again, if you just go back to that, well, the most cross-sectional area is in the smallest vessels, that does make sense. Velocity is slowest, okay? Slowest in the capillary, velocity fastest, right? But however, volume-wise, is different, right? So we're talking speed. So surface area, this is the explanation right there, like I just said. One vena cava, or you have two vena cava, superior, inferior, open them up. Compare that to all of the venules in the body, right? One aorta, open it up, lay it on its side. It's about this, it'll be about like that, right? All of the capillaries in the body, right? I told you it wasn't really important to have that how many 100 million or whatever billion capillaries you have, but now does it make sense why that area spread out together is significantly larger? Yeah? And here's the numbers, gross numbers if you like, okay? So yeah, blood is flowing significantly faster in the aorta, but amount of blood, volumetric flow, is larger in the capillaries. And again, don't remember the numbers, okay? Don't remember these numbers, you guys, all right? Concepts, like I was saying, concepts, okay? So don't put that in your brain. Don't put the 3 to 5 centimeters squared in your brain. Understand that the aorta is the largest vessel, and it's gonna be big, but compared to all the capillaries, not that big, all right? And this is just a chart that sort of outlines that. So you have your aorta here, and just keep using that as an example. The velocity of flow here is at its highest, right? Total area is much lower. So again, inversely proportional. Area is small, velocity is high. Then you move into the capillaries here. You have the highest total surface area, but the lowest speed or velocity of flow. Okay? Breather? You guys need to do some jumping jacks? We're almost to break time. I guess we will be a little bit after break, but not too much more. So, problem with this is blood is a heterogeneous fluid with all types of different cells, proteins, electrolytes, and water flowing through it and through multiple different size and diameter and distensibility of tubes through various different areas of differing gravity, all right? And so it is a complicated equation, but we don't need to go into that depth. Well, here's what we need to do. We need to understand that the basics of this equation right here, which again you do not have to memorize, all right, is that changes in pressure and changes in vascular resistance have enormous consequences when it comes to blood flow or fluid dynamics or replenishment of fluids in a patient, all right? So when you start to ask, why do we have to know this crap? It's because it's foundational knowledge just to understand. When you start to choose a vascular access site, when you start to choose the size of a catheter that you want to catheterize your patient with, when you want to start to choose fluid that you're going to replenish this patient with, when you get to other fluid dynamics, including airway management, this comes into play, all right? So ventilation settings. So this stuff does become important, but we need to understand it at a basic level, all right? Are you going to calculate this in clinic? Nope. Which is why I said you don't have to remember the formula, all right? But we need to understand the principles behind it. So, I want you to draw your attention primarily, real fast, to this R, to to the fourth power. What happens in a mathematical, in a division problem, in a fraction? What happens when the bottom number goes way up? What happens to the overall number? It goes way down, right? So, if you want to take away the main thing, in my opinion, from here, the radius of the tube, the radius of the cylinder, is one of the most important factors in this entire equation. Alright? Everything else does play. Radius of the tube, we got that. Length of the tube, right? The longer the tube, the more resistance. Why? Friction. More friction. Okay? And then viscosity. You guys know what viscosity is. The thickness of that fluid. Like it says, water versus honey or syrup. That has to do with hemoconcentration. You guys will learn about something called polycythemia vera, where you have too many blood cells in your blood. You have thickened blood. So you have an increased viscosity, which you have to understand, especially if that patient has other comorbidities. But, what have we already talked about that takes into account clinically that note on the bottom? Resistance is inversely proportional to radius to the fourth power. And this is a real thought problem, but I want to see. Remember me talking about coronary artery blockages? How big are coronary arteries? Not even this big, right? So how much of an atherosclerotic plaque, how much of an obstruction in that tiny little coronary artery would it take to cut the blood flow to the cardiomusculature downstream from that? Nothing, very much at all, right? So a tiny little plaque increases the resistance to flow 16-fold, which means that subsequent to that blockage, we're getting 1/16 of the blood flow that we need. Does that make sense? So clinically, this stuff is really important. Even a tiny little blockage in an artery, and it doesn't have to be an atherosclerotic plaque. It can be anything else. It can be a vasculitis or something else that causes inflammation, or it can be a patient with systemic hypertension. Now, do you see systemic hypertension? What happens in systemic hypertension? Chronically, we have vasoconstricted arteries. We're clamped down, which means that the resistance to blood flow goes up. Resistance to blood flow, what does that mean? It means the heart has to work harder. The heart remodels. The left ventricle shrinks. Now cardiac output and stroke volume is reduced. So even less blood volume is getting out. You see how hypertension kills people? And why this is sort of important? Just that little bit of knowledge, right? All right. Here's the big one, Puissel's equation. This one you have to, I'd say 35 to 40 questions on this one alone, so. But, now you don't have to know this one, but again, volumetric flow, this is clinically relevant when it comes to airway management, fluid management, all the stuff I've been talking about, okay? Even things you wouldn't think about, like dialysis machines and determining dialysis sites, peritoneal versus hemodialysis. A lot of things come into play here, like where are we going to get good vascular access, where are we going to be able to manage this patient's site and replenish them the way we need to. One minor takeaway on this one, besides what we've already discussed. And does everything I've said so far, I haven't asked if any questions. Does that make sense what I've been saying? Everybody? Okay. So, after this, I think we'll take a little break, because I think it's time. Volumetric flow requires a delta. Everybody know what a delta is? Change in. The Greek letter delta, the little triangle, change in. So it requires a delta in pressure. The beginning and the end has to have a change in pressure, because what happens to an equation, if P represents the delta of pressure, what happens to an equation where the top number is 0? It's 0, right? So regardless of everything else, if we don't have a delta in the pressure, we're not going to have any volumetric flow. All right, and then that comes really a lot more important when we talk about ventilation. Okay, but it does have something to do with fluid management. Why? What would the delta in pressure have to do with something that we've already discussed, maybe in block 1? What is maintaining the delta in the pressure? Heart. The heart beating, the pump that's moving this fluid around. If we have an insufficient pump, then that number gets lower and lower, right? Maybe not 0, because then you'd be dead. But as it gets lower and lower, you have a more and more inefficient pump, heart failure, whether it's right or left sided. What happens? Your volumetric flow goes down. Okay? And if you really want to put, that's good enough. Let's not get too complicated. Anyway, does that make sense? Huh? All right, you guys, let's take a break, and we'll come back in 10 minutes, and we'll finish up. We're pretty close. All right? Okay, so on this one, so it's not that it's greater, it's actually greater in the artery, especially in the aorta, what's coming out of the left ventricle. But what contributes to this rise in the venule vein, you see even here. When we get to the vena cava, it's about the same as the smaller arteries. When we get to like our sort of distributing arteries. It has to do probably, I mean, just with the lack of flow. It hasn't. So, I guess the answer question is, it's not. Did I say it?
Maybe I made it better.
There's more. Oh no. What I was saying. It's like the flow, like the volumetric flow, like the actual amount is greater in the smaller vessels. Is that what you're saying?
Maybe I just made it wrong.
No, I want to make sure that I clear this up for you. So
Earlier, I put down that pressure was greater in the small arteries.
that is true.
And then, see the slide 17. Oh, okay. Okay.
So I think what I said on that one is that volume of flow is going to be biggest in the smaller vessels because more of the blood is in the vein. That's what I was hitting. Not that it's going faster, that there's more stuff.
And I got one more question. So,
She probably has. No, I think it's probably it may be related more to like or like reducing heart efficiency, most likely and then she may have some liver problems or kidney problems too. You get into the mechanics of it, like they call hepatocardial renal syndrome. So like more or less when the heart starts to go, the kidneys start to go, then they take the liver with them and then they do this vicious cycle. And so that can happen where they deal with it. And also, older folks just have less confident valves and vessels. So it may not be anything as nefarious, it's just that her veins are just not getting blood with the Yeah. Depression stocking. Other pneumatic or other PEDs?
yeah, I don't know. Thank you, sir.
Yeah, no problem. Yeah, we're actually got something so that's, yeah, the thicker the more resistant.
More resistance than low pressure.
Yeah, and as you're increasing, the bottom number, which is the end is viscosity, so as you're getting higher on the bottom side, you're taking the top side. So yeah, you have to increase your end, that's Q on the bottom, your Q is going to be smaller, so your force is Q.
Oh, go ahead, I didn't cut you.
No, the resistance is used, there's more resistance. No, 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 if R is going up, it's making it, R is yeah. So as the rate, yes, the rate is getting lower, the resistance will be very yes, I get it. In person, but You guys remind me, you know the two old Muppets, Waldorf and Statler? From the, you guys, that's you, every time I look up, you're gonna.
I'm just trying to get as much information as I can, and I record it, and then I got it.
I know.
And then go back and.
Like I said, I just gotta entertain myself, so I'm like assigning people personalities. I don't know when we stop, so I'm just like up here. I'll just stare off the slides like this.
So you like the people who guys that are like, yes, people who guys that are like always hesitating to play.
All right, hello. I'm gonna go back to this just to make sure I explained it in a way that is coherent. So, the main driver of this equation is what again? Little r, right? Little r. And what happens when little r becomes a big number? Big R goes down, right? Radius goes up, resistance goes down. That's the takeaway. Does that make sense? Okay. Okay. So, other variables that influence blood flow, because it isn't that simple, because why would it be? Cardiac output, so the physical amount of fluid being ejected, okay? Resistance, systemic vascular resistance, vasoconstriction, vasodilation, hemoconcentration, other fluid, things that create higher resistance, radius of the tube, length of the tube, everything we just talked about. Compliance of the vessels themselves, not just compliance of the ventricle, compliance of the vessels. So if there's hardening of the arteries, everybody's heard of that, atherosclerosis, hardening of the arteries. If they're less compliant, less distensible, less able to accept flow, then we're gonna have less fluid and higher resistance, right? And then so on, and viscosity we're gonna talk about here in just a second. So cardiac output, we already know this, right? Theoretically. Okay. So stroke volume, how much the blood squeezes out times the heart rate. That's our cardiac output. As our pump becomes more and more inefficient, weaker and weaker as we move into heart failure, cardiac output goes down. So we have less volumetric flow. Everybody understands that, okay? If we have an efficient pump and we exercise, for example, then our stroke volume goes up, cardiac output goes up, so we have a more efficient pump, we have better, higher flow. Simple, right? Simple. Resistance and pressure loss, so losing pressure over the course of the system, as I've alluded to. When you leave the left ventricle, obviously you have the highest amount of pressure, and then when you return back into the right atrium, you have very, very low pressure. The right side, the venous side, is a much lower pressure system than the arterial side, although it does have a higher capacity, right? Capacitance vessels, that's where the majority of our blood reservoir is. Remember that chart, where the pie chart, where is the most of our blood at any given time? The venous side, right? Okay. Compliance, we talked about this. Hardening of the arteries, right? This is a little, it gets a little redundant, but again, saying the same thing over and over again sometimes helps it stick. So, more compliance, more accommodation, greater volume, greater flow, more efficiency, sort of is where we get to with that. Okay. Veins are more compliant, I think I mentioned that earlier, right? Compliance vessels. Remember we talked about for a given size of a large vessel, veins are going to have a larger lumen, right? Able to accept more compliant. Does it make sense? Does it make sense that that's why the majority of our blood would reside there at any given time? It's more spaced, okay? This one should be obvious. If you have less fluid in the system, you have less pressure, right? You guys familiar with the concept of bleeding? Okay. So when you're losing blood, you have less pressure, okay? There you go. Thickness, viscosity, again, on the bottom, right? So it increases. Right? The more viscous, the thicker the fluid is that's moving through, the higher the resistance and then the lower the flow, right? Okay? And again, this does come into play, right? When you're hemoconcentrated at altitude, when you're hemoconcentrated because you're a smoker, when you're hemoconcentrated because you have polycythemia vera, when you're hemoconcentrated because you're dehydrated, okay? So there are plenty of clinical applications to this kind of stuff. Blood vessel length, again, longer tube, more resistance. Again, blood isn't exactly a Newtonian fluid, right? It has weird properties, it has solid components, it has proteins, it has all kinds of things flowing through it, flowing in it, I should say, more accurately. And so, the longer that it has to come in contact with the tube wall, the more friction, the more resistance. All right, where does that come into play? Where is an easy clinical application for all this stuff we've been talking? Anybody ever given an IV before? Anybody know the difference between gauges? An 18 gauge is bigger or smaller than a 14 gauge? Smaller. Smaller. What flows faster? 14%. Right? That's it. Right? And if you're going to use a shorter catheter, is that going to be faster flow or slower flow? Faster. Alright? That's why the answer always used to be 2 14-gauge catheters. Now we know that's really dumb and it just blows clots out and kill people. But that's why it used to be that way. Alright? Now we use 14 gauges for other stuff, but anyway. That's a simple application. Simple, clinical, practical application that probably everybody can conceptualize. Alright? Also here, it seems like a dumb example, but it's not. We've talked about angiogenesis, neovascularization, creation of anastomoses, and so on, right? You see this, if somebody gains weight, adipose tissue, they gain a significant amount of new blood vessels to feed that adipose tissue, which means that their heart has to work harder to push blood farther and farther into those little tributaries that are new. And so what happens? Increased vascular resistance, increased heart rate, increased pump, and the mechanisms that we've been talking about. Are you stretching? You have a question? Yes, ma'am. What's up?
Since we don't lose adipose tissue after we gain it, do we lose blood vessels as well, or if we lost the people to
If you lose the weight, the blood vessels sort of do regress. I know that one for sure. I still have to answer your question from yesterday. But yeah, if you lose the weight, you're going to lose those extra blood vessels as well. I mean, just because of the tissue shrinking, so you don't have, the area is not as widely distributed to need those tributaries. Yeah. So again, it helps. Why do we recommend diet and exercise? I'll tell you guys this. You know what the hardest thing to get patients to do is? We call them therapeutic lifestyle changes. Stop smoking. Stand up every once in a while. Walk. Stop eating shit. Nobody wants to do that. What do they want? Ozempic. That's what they want. Yeah. All right. And again, I don't know why they've chosen, or I guess I have chosen to switch from radius to diameter, but does everybody know what radius and diameter are, how they're related? There you go. Yeah. Radius, diameter. Okay. What? All right, so anyway, increased diameter, decreased resistance. So the bigger the pipe, the less resistance. That's what it says. Okay? And this is what we've been talking about, and how sort of contraction with the precapillary sphincters increases vascular resistance, how clamping down of any vessel really significantly increases vascular resistance, right? So going down by half increases the resistance by 16-fold, right? But even a fraction of that is still a significant increase in the resistance to blood flow, all right? So things that cause vascular resistance have significant clinical consequences to somebody who might already have high blood pressure, or who might have a cerebrovascular valve formation in their brain that can't accommodate higher pressures or they'll explode. Okay, things like that, right? So that's conceptually, clinically, why this stuff becomes important to understand. And maybe we've beaten the dead horse, but it does make a difference later on when you're getting into the clinical application courses. All right, does that make sense to everybody? All right. Good, because that's it. So which one pulls from the interstitial space into the capillary? Blood colloid osmotic pressure. That's right. Pulling back into, what's the other word for pulling back into the capillary? Reabsorption, right? Exactly. And what is the most easy thing, what have I talked about multiple times, that is primarily responsible for blood colloid osmotic pressure? Albumin, protein, yes. Albumin fiber. A, that is correct. Veins and venules. Yep. A little ball of something comes up to the cell membrane and gets expelled. Exocytosis. Okay? Thank you for your service. I will see you tomorrow.